Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast today. My name is Terry Fletcher, and actually, I am recording on Easter. So happy Easter to everyone that celebrates Easter, and for those of you that do not, happy day off. So hopefully you're getting to do what you want to do and hang out. I actually went to brunch early with some friends and family, and I knew my daughter would be taking over my television today, watching her baseball game with her Cleveland Indians. And I'm a Pittsburgh Steelers fan, well, that's football, but I'm a Pittsburgh Pirates fan as well. And then also a Dodgers fan, which we don't get on TV very often, but they've been putting them on TV lately. So I thought it was time to come in, record, and then watch mine via iPad. So when I'm done. And there's amazingly no one here working at where my satellite office is. So I lucked out today with some time. I know some of you think I'm funny when I say stuff like, I can't believe people aren't working today on an Easter Sunday. For those of you thinking about going into business for yourself, well, first of all, I'm going to have a new podcast up here in about a couple weeks called The Business Collective with Terry Fletcher. And it's how to go from employee to entrepreneur and ease into that transition, mainly in the healthcare field. But if you think that it becomes all about just you get to put your feet up and you're working from home in your slippers and basically you're down to 20 hours a week, think again. It's definitely interesting when you work for yourself. You just have to make sure, that you have a steady income and cash flow, and your responsibility is everything that's happening. So just know that it's amazing to me how many people do work on the holidays when they work for themselves, and I am definitely a culprit of that, but I still get my family time in, still get my friends time in, and I basically make my own schedule, but it's a lot of hours. So with saying that, before I get started, I would like to say hi and thank you for the kind direct messages and ratings and recent reviews I received this week. It's so humbling when I get those, and it really just puts a smile on my face for the rest of the week. So I want to shout out Flavio, Samia, Tony with an I, that's a female Tony, Darnique and Angela. You are all so great to let me know that you love the podcast. And Ashley, thank you for your great review on iTunes. If you know me at all, I am not a squishy person. I'm a nice person and everybody seems to like me, but I'm not really squishy. But you guys are giving me all the feels here. My daughter reads this stuff and she's like, Mama, you have some cool fans out there. And I'm like, you know what, honey, I really do. So thank you again. And I just live for the positive feedback. So anytime you want to contact me and let me know what you're thinking about the CodeCast, just let me know. So my topic today, I wanted to speak to the billers and collectors out there. Obviously, the coders need to listen into this, and even the physicians, mid-levels, administrators, because there's a lot of information that could affect your job directly as well, or even indirectly. And so we're going to look at insurance claim denials. Now, I've done some things on revenue cycle management, which is from the time you take the patient's information when they walk in or even when they call the office to all the way back to the collection and appeals process until when they're discharged from the practice. But today, it's those practices that can eliminate the most common reasons for these denials that will experience a smoother revenue cycle and find greater financial success. So based on a survey of 100 insurance payers, including Medicare Contractors, here are the top 13 denials that are becoming as routine as submitting a claim. But first, the CodeCast Podcast is also brought to you by CareCom, a Danish software company leading a global, centralized terminology solution for interoperability solutions. It isn't about cutting the human out of the equation so much as giving the humans tools to improve healthcare. Carecom.com. Okay, so what we want to look at today is really part of claim denials as it relates to your office and kind of what are the payers seeing? Let's look at it from a payer perspective. And when we looked at the survey, it was interesting to me how payers are saying, we're seeing these denials just like we're seeing claims submitted. It's crazy how it never stops, and we're not seeing kind of a learning curve on how to curb it within the practice before the claim goes out. So let's take a look at some of the top denials that are out there and see what you can do to maybe improve it or maybe assist your practice into not letting this happen before the claim leaves the office. So number one, a duplicate claim was submitted when a practice hasn't received reimbursement. I see a lot of practices and billing offices that will set their computers to automatically resubmit a claim when reimbursement hasn't been received yet. Well, that can really mess up your revenue cycle, because what happens is that you'll either get a duplicate payment or it'll pen the claim because the payer is only seeing duplicate claim. And so now they're saying, well, we've already received it twice. Even when you haven't received reimbursement, it messes up on their end as far as what they're going to do with your claim. So you need to have people working your AR so that doesn't happen and they know what's been received, what hasn't been received, and not to just automatically, your computer automatically send out another claim form just because it hasn't been received. That's not going to help you at all on your collection process. Now, number two doesn't surprise me. It's the patient isn't eligible for services because his or her health plan coverage ended and the patient hasn't shown proof of new insurance. So being on top of that is really important for your front desk. They're the ones where the patients keep coming in and, they're seeing them kind of routinely, but insurance plans change. Administrators, I should say, of that plan can change. And some patients have, especially in the November till April area, everybody has an option. If you were HMO last year, you can go to PPO, or if you were PPO, you could go to EPO, but everybody can change a plan even though the insurance card may look a little different or look the same. And so being on top of that and understanding that it's really also the front office responsibility to ask, has anything been updated? And it should be part of your sign-in sheet as well, because I think some patients are only asked, has your address or phone number changed? And that's a reasonable request, but has their insurance changed since you've been in the last time? And so make sure they are on top of that. And if they say no, say, okay, can we get another copy of your card? I'd be looking at it all the time. Number three, the patient hasn't met the deductible for a calendar year. And so it's not so much a denial, even though that was put in this survey, as it is you're just not getting paid. So your denial code is basically saying that it's applied to the patient's deductible. The patients will tell you what their deductible is, and now you can go to, that national website I gave you last time, just making sure that your patients are eligible. One of is Quizlet, and then there's CareCloud, and there's P-Verify. So there's all kinds of different websites that you can find if a patient's deductible has or hasn't been met. So that's a really big one. Now, number four is one that actually concerns me because there should be a lot of eligibility verification within a practice. And number four says some services are bundled. So denials, for example, on laboratory profiles with multiple tests don't qualify for separate reimbursements, or an all-encompassing rate covers the minor procedure and the pre and post procedure visits. So the provider basically receives one combined payment. But the other thing on top of this is also, and I get a lot of you are members of my Coding Corner service. I mentioned my online service for coding questions. And I'll get an occasional client that will say, Terry, we just took a webinar or we took some kind of educational piece from Medicare, and they said we're supposed to be coding this way or that way for a certain service. And so, I'll look at it and I'll say, well, haven't you taken one of my webinars or workshop in a while? Because that's been out for 3 or 4 years. And I'll see something that somebody's trying to code for that's very dated. And I'll say, it's great that you're part of this service, but you still need to update yourself with educational pieces, because my service is a troubleshooting service. So you have a problem with, a claim or a report, or you're like, I just don't know how to code this. You can, shoot me an email and say, take a look at this. How would you code this? This is what I came up with, or we got a denial on this. Can you help us with this? So for understanding your bundling services and really being on top of that and knowing what's expired and what's changed, that's really important, not just as a biller and a coder, but as a collector as well. You need to be on top of it too, so that you're not out there spinning your wheels trying to collect something that isn't collectible. Which leads us to number 5, and that's the benefit of the policy has been exceeded or maxed out, such as the maximum allowed number of physical therapy visits covered by a health plan within a calendar year. We know Medicare puts a certain number on that too, along with the commercial plans. So know your policy information, know the limitations. Screening colonoscopies, they allow one for a high-risk patient within a 2-year, 24-month period, or the initial one for a patient who's age eligible. So there's some things that you have to be very mindful of before you submit, otherwise you would get a denial. Number 6, the claim form is missing a modifier or modifiers, or the modifier is invalid for the procedure code, as in the case of bilateral codes billed on both sides. So modifiers it's such a fascinating thing for me. I actually have a modifiers webcast coming up on May 15th. It's going to be May 22nd. It's going to be at 8 a.m. and Pacific Standard Time, but we're going to talk about all modifiers. But when you look at the top 13 of denials, and that's number 6, really looking at modifiers and the misuse of modifiers. And I see that all the time. I see people throwing out the 59 when it shouldn't be thrown out, or not using their X modifiers, or using the 25 modifier incorrectly, just not understanding the modifier process. And they're your key to reimbursement. You could really make a huge impact on your reimbursement if you know how to use your modifiers in the healthcare field. So really check out my webcast on that. That's coming up in a couple of weeks here. Number 7 denial is the inconsistent place of service is marked on the claim form, such as an inpatient procedure billed as in the outpatient setting. And I'm telling you, that's worse than almost anything, only because your patients, remember, whenever there's a denial, they also get an EOB or some kind of in-mail alert that something hasn't been paid. And if they're seeing something that says they were in the hospital when truly they were not in the hospital, or vice versa, saying that they were, inpatient versus outpatient, and there is a big difference in what their share of cost is going to be based on that place of service. But if your place of service, meaning inconsistent, means that you had it authorized as an outpatient, but the hospital decided to authorize an inpatient, or you just didn't have a link there. There was not a consistency within where you had it done versus what was authorized, and also what the facility had, you're going to see a denial. And those are really hard to fight sometimes, especially when you go back on it. So always make sure that you're understanding what's appropriate for that place of service. Same thing as if you provide a service, the technical portion, let's say you're reading EKGs in the hospital setting, but your physician reads them, let's say on a download once a month through their own personal office computer, and they put all the place of service as office since that's where they read them. That's incorrect. It should be where the technical portion was actually done in the hospital setting. And so that can really kind of be a problem. A big problem when it comes to denials. Number 8 is a particular service isn't covered under the plan's benefits, or there appears to be a lack of medical necessity. So in another example, there could be a mismatch between the actual diagnosis of the service performed and then what was actually performed or appropriate. I know I had, when I mentioned EKGs before, I had a practice that was having a rough time getting these paid, and I noticed that they would use just any diagnoses that the patient was admitted with to try to bill out an EKG. And one physician in particular, he was called in to do a pre-op on a patient with an ankle fracture, and they were going to have an open reduction. Well, as you have to know, ankle fracture is not going to pay for an EKG. There has to be something on the pre-op or a heart condition or something that reflects that procedure or that diagnostic service needed to be done. So a particular service that's not covered, you really need to know what your covered benefits are when it comes to the linking of the diagnosis codes. Number 9, the claim is deficient in certain information. So it may be missing a prior authorization or the effective period of time within which the pre-approved service must be provided for reimbursement to occur. Most authorizations that you get, they're usually for 30 days. And so if you get that and then the patient decides to cancel or wants to reschedule, and you push that authorization off to, let's say, 60 days or 90 days to when that patient's going to have the procedure, then it may not be covered anymore because it also gets wiped out of the facility if it's a procedure that needs to be done inpatient, because the H&P is no longer valid. So that's the history and physical, basically, that they're cleared to have the surgery. So that's a big one, and that was number 9 when it comes to denials. Number 10 is that there is a coding or data error with mismatched totals or mutually exclusive codes. So something's not calculating correctly, or there's a certain amount of times you can bill a certain procedure on a given day. That's what the MUEs are. They're saying they're only going to allow this code to be billed 1 or 2 times a day or up to 3 times a day. And so you need to know what those codes are and what those frequencies are, or it'll be really tough to get those reimbursed. Number 11 is it may be necessary to coordinate benefits when dual coverage issues arise. Now, I know some people say, you mean like when we have a secondary insurance of workers' compensation? No, I mean when you have a patient that has dual coverage, meaning that they're covered by themselves and then they're also covered through a spouse. Remember, it's whoever's birth date, birth month actually, falls first in the year. So for example, my husband's birthday is in September, mine's in October. And so we both have dual coverage. Well, his is primary and mine is secondary. And so that's just a rule. Now, unless you've actually specified to the insurance company that you want yours to be primary, then you need to look at those coordination of benefits and make sure that you know when you're submitting that it's appropriate. Same thing is if your benefit policy is under any kind of managed care plan. Make sure whoever is entering in the insurance information is picking the right place where it needs to go from either an electronic submission or from a paper claim if you're still doing that. Sometimes I'm seeing it going to the wrong place. And so that can be one of the denials as well from a coordination of care standpoint. Deadline has passed. If a claim isn't submitted to the insurer within the permitted time that's within the contract, then it is going to be rejected, or at least it's likely to be rejected. So the limit to file can be as short as 90 days from the date of service. I actually saw a recent one that was 30 days, if you can believe it. And so making sure that the doctors are closing out their charges, they are signing them, or authenticating the record is another way to put that, so that they can be submitted immediately. Otherwise, you could be losing money based on the fact that you don't have documentation, so you can't submit the claims, and there you are, you're kind of struggling to get that paid. And then the last one on this list, and again, these don't always include everything, but these are the top 13 from that survey of over 100 payers. Number 13 says errors or typos that were made while collecting pertinent information from the patient or during the data entry process for the claim. There are so many issues when it comes to transposing numbers or inaccurate information being entered into your system. It's just, it has to be something that is a priority, that's a project that is really mindful for people that they need to be accurate as possible. Because if they're not, it rolls downhill and the billing office will be pulling out their hair if that information is not accurate. So make sure you have really good, conscientious people that want to or take pride in their job enough that they know that accuracy is key. Otherwise, that will be a huge error for you. Okay, so I want to get to my coding questions. And my first one is about a Mohs procedure, MOH''S. And what this is it's used to treat skin cancer, and the surgery has a unique benefit because during the surgery, the surgeon can see where the cancer stops. And that's not possible with other types of treatment. And so that's the advantage of really this procedure. Mohs has a high cure rate, and it allows the patient to keep as much of the healthy skin as possible because the surgeon only removes the skin with cancer cells. And this is especially important when skin cancer develops in an area with little tissue beneath. So like an eyelid, an ear, or a hand, or kind of the bottom of the lip. I see it most with basal cell carcinoma and with squamous cell carcinoma. But here's the question. So I just wanted to give you a little bit of background before the question came up. So here's the question from one of my Missouri clients. So coding question, a composite graft with harvested cartilage. Hi, Terry. I listen religiously to your podcast, and I was wondering if you could answer a quick question for me on the Mohs procedure. I'm going to join your Coding Corner membership today, and actually that physician did join me, so I appreciate that. So I performed a composite graft, CPT code 15760, and harvested cartilage from the ear on a Mohs procedure. Can I report for the harvesting? If yes, what code do I use? Okay, so yes, you can report both the 15760, which is the graft composite, full thickness of external ear or nasal, including primary closure or donor area. And you can also code the 15040. That's the harvest of skin for tissue cultured skin autograft, 100 square centimeters or less. And that's for harvesting the graft. So these two codes are not bundled under the National Correct Coding Initiative, or CCI. They're not in the MUE, and they can be reported together, and yes, are typically seen as a code pair when performing this type of procedure. So you do get both codes in that scenario. Our next question is about the new Medicare cards. This comes from one of my Texas clients. So Terry, we have a question. We posted everything available from the Medicare's website for our Medicare patients to ensure that they know to bring their new Medicare beneficiary identifier number and card once they receive it. But when do providers have to switch to using the MBI exclusively? Okay, so you should start using the MBI number as soon as you're aware that any individual patient has received this card. The MBI number is designed to really improve security for Medicare beneficiaries and help protect their identities because it provides a different means of identifying each patient rather than their Social Security number or the health insurance claim number, which is based on a Social Security number as well. All of the MBIs should have been distributed by April of this month. So they're saying by the end of this month. So all of your patients should have their MBIs available. And then remember, it looks very different from a Social Security number or the health insurance claim number. Just like with the health insurance claim number, the MBI hyphens on the card for illustration purposes, but do not use the hyphens or spaces on the transaction. The MBI uses numbers 0 through 9 and all uppercase letters except for S as in Sam, L as in Larry, O as in ostrich, I as in igloo, B as in boy, and Z as in zebra. So according to a bulletin released by Medicare Learning Network on March 6, 2019, they were pretty clear about not using hyphens or spaces with the MBI number. Otherwise, they said you will be rejected. And the MBI, they said, will replace the health insurance claim number and, of course, the Social Security number. And now the other thing they said is the effective date of the MBI, like the old health insurance claim number, is the date each beneficiary was or is eligible for Medicare. Until December of this year, so last December 31st of 2019, you can either use the health insurance claim form, HICN, number or the MBI in the same field where you've always put the health insurance claim number. But I'm going to strongly advise you, as soon as you get it, plug in the MBI number as soon as possible. And again, make sure that you have somebody who that's taken this on as a project, that the information is accurate when inputted. Our coding questions were brought to you today by Gaffey Healthcare, better technology, better results, gaffeyhealth.com, and Keck Medicine of USC, over 500 internationally renowned physicians at a leading California academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, keckmedicine.org. Okay, so coming up on our webinar schedule, I mentioned my modifier madness, which basically is going to cover as many modifiers as I can get into an hour webcast, and that will be on May 22nd at 8 a.m. Pacific time. I have a 4-part series on the hierarchical condition category codes, the HCCs. We're doing part 1 and 2 on 514, and then part 3 and 4 on 521. And then fracture care coding and billing on 515. So make sure you check out my website. I actually have a new webinar page. So we used to have to go through, you click on my site, you go to services, then you have to click all the way through. You don't have to do that anymore. Just go to terryfletcher.net and click on webinars, and a calendar pops up on the screen. So you can see our webcasts, our live seminars. And I also wanted to let you know, we have it on demand as well. So if you order it and then you want to listen to it later with your materials, you can do that as well. We'll send you a link and you just pull it up and it'll all come up for you, and listen to it at your leisure. They are booking really well right now, so we really hope to have you or see you on one of our webinar series. So my personal tidbit this week, well, first of all, last week, I didn't know if Tiger had won the Masters or not, but he won. Yay. I was pretty excited about that. It was such an exciting day of golf on Sunday last weekend. It was so fun to watch. I love a good comeback story. I just like it when people can, reinvent themselves. I just think that's a fun thing to have happen. Another thing is that something somebody requested, which I thought was really funny, is they said, I know I've listened to your other podcast, The Bun Life, which I'm actually going to be rebranding, by the way. My daughter and I are going to do it now. So I'm not going to do it anymore with the previous person I was doing it with. So my daughter and I are going to pick that up again. But we have recipes on the site. And one of my specialty recipes is deviled eggs. So I also like to do with my friends a deviled egg bar. So if you're wondering what to do with all those hard-boiled eggs you made or colored for Easter, there you go. And I'll have that up on my website this week. I know that sounds like a departure from all things healthcare, but I like to cook, and sometimes it's just fun to do something else. And so hopefully you'll find that fun. So I'm not going to do that all the time. This is definitely not the Food Network channel, but you'll see a couple things up there on my blog. So just check it out when you can. And then next week will be our Top 10 Tuesday. And again, I will focus on prior authorizations. So we'll give you your top 10 options to make that tedious part of your job a little bit easier, which is probably good because April is National Stress Month, if you didn't know that. And I'm going to also give you some tips on how to make your job a little bit just easier to tackle. It's not realistic to expect to love your job every minute of every day, but I want you to be able to embrace it as a positive, more often than you might feel that you do. So hopefully next week, between our prior authorization tips and then also looking at a little bit of stress relief in our stress month of April, as we end it out, that will help you. So everyone, make it a great day, and thank you again for listening to the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.